Sort of just an overview to make people think about where we are with our visceral pain. Now, do we do this? Yes, we have a large transplant, we have a transplant service at NJMS, and we are sending patients constantly that have had successful transplants. They're still complaining of pain, and this is a modality that we do want to utilize a little more of. With our patient population, sometimes it's hard to get insurance approval, but this is something we're looking at because we really don't want to have high opioid loads in these patients. So for us, this is a very important topic. I want to thank you for your time. And I'm happy to say that we are actually on time today, which is somewhat unusual for our meeting, which is wonderful. Now we got to reach out to Chicago, but Kenny is actually a true son of New Jersey, and Dr. Candido has been in all phases of practice. He has been an academic. He has multiple publications. He's now in a private practice, but it still keeps his academic work going. And he also, if this career doesn't work out, he is going to start a football through the basket league, and he will be the founding member of this. You know, I sit and wonder why, but he really enjoys it. So, Kenny, it's a pleasure to have you back. Thank you so much.
Thank you, Dr. Kaufman. Thank you, everybody. It's a privilege to be back here in the great state of New Jersey, as Dr. Kaufman pointed out, my home ground, my stomping ground, where I went to high school and college, and where my entire family continues to reside. Privileged to talk this morning about avoidable spinal cord stimulator complications, and I should point out, in the last 4 meetings I've been to, I've been asked to do the complications talk. I'm starting to wonder if the word is out about my own clinical practice and why I'm always the complication guy. I don't have any disclosures as relate to this educational activity per se, but I will describe 3 important sayings that underlie how we should approach our patients and how we should look at what has been done to try to minimize or avoid complications. So those who forget the past are compelled or condemned to repeat it. This is from the great George Santayana. It was Professor Alan Winnie's most famous saying. He always repeated it. We must learn from the lessons of the past. It's better to be lucky than good. That certainly applies to myself. And good judgment comes from experience. However, unfortunately, experience comes from bad judgment. Very important paper. I'll only give you a smattering of literature, which I think is critically important when you're considering how to avoid complications of spinal cord stimulation. This is a recent publication this year, and it comes again from one of our distinguished speakers here at this meeting, Dr. Falowski, as well as Dr. Abd El-Sayed. And they looked at anticipating preventing complications in spinal cord stimulator implantation. I encourage you all to read it. A very important paper which gives some great tips to try to stay out of trouble. Another important paper from Salim Hayek at the Case Western Reserve University Hospital out in Cleveland, who looked at his own data from his own center over many years, 8 years of experience showing over 234 implants. They actually recruited about 360 patients. And he found an alarming incidence of complications with spinal cord stimulator use up to 35%. Think about that number. Is that really realistic? Are 1 out of 3 patients who have a spinal cord stimulator having a complication? In point of fact, the answer is yes. What have we done about it to try to minimize those complications? A large meta-analysis and systematic review, which was published a couple years back, 2 years back, by Amy Blackburn, looked at all the world's literature over about 40 years, and they were able to identify 32 papers, many thousands of patients, finding the overall complication rate with spinal cord stimulation implantation is about 21%. So we know somewhere about between 1 in 5 and 1 in 3 patients is going to sustain a complication related to spinal cord stimulation. And Blackburn suggested that there are 3 important categories of complications. 1, equipment related, 2, technical related, which is much less common, and 3, medical issues such as infection. I'd like to go through some of these with you and talk about what we have in our ability and our capacity to possibly try to limit our patients' exposure. And why is it important? Well, it's important, first, do no harm. We don't want our patients to be harmed, but it's also important that these situations, they often lead to litigation, and I'll show you some sobering data in that regard. So according to Hayek, the number one related spinal cord stimulator complication is hardware failure. In his 34.6% of complications in his own unique practice over 8 years, 74.1% of the complications in the patients who had complications were related to hardware. And we're talking about lead migration and lead failure or fracture. Gratefully, biological complications are at a lower incidence. However, as Fulowski and Provenzano pointed out just a few years ago, we're still having about a 3% incidence of infections with spinal cord stimulator implantation. That's a very high number. And if you look at, for example, the orthopedic literature for joint total arthroplasty, knee or hip, they're down to about 2%. They continue to make refinements, and they continue to see a reduction in the complication infectious rate for their patients. We do not see that with neuromodulation, even in contemporary practice. So, if you have a complication, obviously, that could lead to an adverse patient outcome, and sometimes patients in this litigious society that we reside in will institute a medical negligence claim against you and perhaps your practice and perhaps your hospital. Nice paper from Kameth and Alan Kay and others that looked at 30 years worth of closed claim data retrospectively. And what did they find? And it's important to know this. They found that in about 60% of cases, you as the physician would be successful in litigating a medical negligence claim with interventional pain. And I'm talking about all interventional pain: epidural, steroids, intrathecal drug delivery systems, spinal cord stimulator use. You're going to be successful in defending yourself about 60% of the time. However, when the cases are performed in the operating room, you're much less likely to be successful, and the patient is prevailing in about 83.3% of cases. Now, the awards, the median award for an interventional pain procedure where there is a payment is about $333,000. However, the highest award is up to $36.5 million. So there's a huge variability in range in what juries find to be fair and reasonable in terms of compensating patients who are seeking damages for some type of harm. And the procedures that are performed in the operating room are much more likely to be in the favor of the patient, with a higher median payment of about $450,000. Procedural error, that means that you made a mistake in how you performed your spinal cord stimulation, that is associated with the highest level of both suits, successfully and otherwise. If you look at the data here, epidural steroid injections, for example, that lead to a complication, you're about 2/3 likely to be successful and prevail if you're the clinician, meaning the patient does not get paid. However, with spinal cord stimulator implantation, those numbers go down to about 40%. So 2 out of 5 cases you'll be successful, 3 out of 5 cases the patient will be successful. Look at the data for intrathecal drug delivery system. The patient is always successful. Again, these are procedures performed in the operating room. Small number of cases in this retrospective analysis. Only 7 representative cases, but the patient always prevails. So the data for spinal cord stimulation is not as good as it is, for example, for epidural injections, but physicians are still somewhat likely to prevail. So what are the preventable things associated with spinal cord stimulator? How about a headache? Well, we can't always eliminate every dural puncture, but we can treat them and try to minimize the consequences. That includes both putting the patient at bed rest, offering early intervention like autologous epidural blood patches, caffeine intravenous therapies, abdominal binders. Some people use epidural saline, although I do not. Worsening of pain, failure to derive appropriate stimulation, technical failure, the number one issue associated with neuromodulation. The worst case scenarios are infection, paralysis, and death. Gratefully, death is a sentinel event, as is paralysis associated with neuromodulation. These cases are few and far between and rarely reported in the medical literature. Obviously, they are catastrophic when they do occur. Let's talk about infection. We don't have time in the time allotted to go through all the scenarios, but the Center for Disease Control has classified surgical site infections into 3 broad categories: superficial incisional, redness, pain, swelling, or heat. In Spanish, they say dolor, rubor, calor, and tumor. Deep incisional, and where there's pus or an abscess, and of course, organ space infection. That would be, in our case, with neuromodulation, something like an epidural abscess or an osteomyelitis type of technique. So classification: superficial surgical site infection, fairly easy to identify, pretty easy to treat. Aspiration of the seroma when it occurs is something I recommend, although there's no literature in support of that practice. Some clinicians and authorities would implement watchful waiting. I aspirate them. I do C-reactive proteins and erythrocyte sedimentation rates and follow the patients and provide antibiotics. Deep surgical site infection where there's a pus, that's much more of a calamity requiring urgent neurosurgical or general surgical intervention. And of course, epidural abscess, space-occupying lesions, osteomyelitis where there's been infiltration of the bony cytoarchitecture by some type of bacterial process. Terrible. Surgical site infections, the risk factors. So I was here to talk about avoidable complications. What are those risk factors that we have in our control? Clearly we don't do cases involving the bowel usually or typically. So endogenous contamination is not likely to occur in the cases when we're providing neuromodulation. Exogenous contamination, for example, with prolonged operations, that's something which is under our control. If it's taking longer than 90 minutes to perform an implantation of a spinal cord stimulator, you're probably an outlier, you're probably beyond the 75th percentile of implantation. That is something which can be perhaps remedied or ameliorated by education and practice. And diminishing the efficacy of the general immune system while we're implanting foreign bodies, of course. The National Nosocomial Infection Surveillance System listed 8 risk factors. I'm going to go through them with you briefly, but a patient with an American Society of Anesthesiologists classification of 3 or greater is at a higher risk for an infection. Operation classified as contaminated or dirty. In fact, we don't typically do them unless we're removing a patient's device from our prior implantation where there's been an infection. And an operation lasting over T hours, where the time T is the 75th percentile, that's an important consideration. So there are 8 risk factors considered by the CDC in surgical site infection to be consistent as independent factors for why somebody might have an infection. We can't control the patient's age. We can't control the patient's ASA classification. We may be able to control malnutrition, low serum albumin. We cannot control if they've been subjected to radiotherapy or if they've previously had chronic steroid use, although we can elect not to perform our procedures in those patients. Obesity and smoking were previously considered to be high risk for infection. Recently, Dr. Falowski and Dr. Provenzano and others looked at these phenomena and found that they are not likely to be consistent with patients at high risk for infection. Let's talk about smoking and let's talk about obesity. And the reason I do that is because I studied this phenomenon. Regrettably, one of the great regrets of my career is that I didn't publish this data. In 2012, 2013, I studied 64 patients. We presented our data as abstracts at the American Society of Regional Anesthesia meeting on smoking and obesity. We were trying to get 250 patients because my research associate, Nick Nezovich, thought that would enhance our statistical analysis, and Nagy McHale beat us to the punch, and he published great papers on all of this. I tip my hat to him, but I wish that we had proceeded with our publication. So smoking and obesity did not interfere with the efficacy of spinal cord stimulator use in terms of success rate, and that was for BMIs up to about 45. Obesity did not affect the efficacy of spinal cord stimulation, nor the risk of complications. We did not see higher risks of infection with obesity, lead migration, revision, or reprogramming. And smoking, that is defined as more than 10 cigarettes per day, was not associated with a higher risk of infection, but did have a higher associated risk of lead migration in the first 64 patients that we studied, and this was consistent with our data up to 250 patients. So what are the concerns with infection? Well, infection leads to readmission. It leads to increased patient costs, for example, and of course, there's a higher risk of morbidity and even mortality associated with infectious rates. And we have not done a great job of minimizing infection with spinal cord stimulator use. Nice paper from Tim Deere and Bob Levy and others, the appropriate use of neurostimulation, the avoidance and treatment of complications of neurostimulation therapies for the treatment of chronic pain. Some of the take-home messages here were that evidence and clinical experience are critically important to minimize complications with neuromodulation. So it sounds intuitive and inferential, but yet and still a lot of people don't avail themselves to increased enhanced education and to increase treatment. And of course, 30 to 40% of patient complications lead to revision, and we should base our avoidance of this complication using CDC guidelines. That you can see here what the risk of implantation is for other consistent medical interventions, including cardiovascular, orthopedic. The risk of a joint total arthroplasty of knee and hip is down to about 2%. We're still at about 3% with implantable neuromodulation devices. Systematic reviews have shown up to 4.6% of infection for implantable devices. Some studies, like the process study from Medtronic, which compared neuromodulation to conventional medical management, actually found an 8% incidence of infection or wound breakdown. And of course, the best case scenario is that the patient has increased surveillance and antibiotics. The worst case scenario, of course, can lead to morbidity and mortality. Nice paper from Nagy McHale looking at what types of neuromodulation have the higher incidences of infection. He classified the patients as having failed back surgery syndrome, CRPS, and neuropathy, and they found that the highest incidence of infectious complications was with failed back surgery syndrome, followed by neuropathy. The lowest incidence was in CRPS. A paper from Rudiger and Associates showed that the risk of infection could be as high as 13%, and Mitch Engel showed that the highest infectious rates were consistent with the NNIS risk level. That seems also intuitive and inferential. Tim Deere, Dave Provenzano gave us some recommendations and guidelines: weight-based antibiotics, appropriate hair removal using clippers immediately prior to surgery, and the appropriate agent selection for skin antisepsis. It seems that chlorhexidine and alcohol is the best, and there's a level of evidence from the CDC of 1B in favor of that preparation, and using hair clippings is level of evidence 1A, very important. So any surgical site infection, chlorhexidine alcohol is superior to the use of betadine. We know that. Weight-based antibiotics, very important. We should all avail ourselves of that. And I need exactly 1 more minute. Is that okay?
Go ahead.
Okay, thanks. Sorry, I'm going a little bit over. You will take note that I was only allotted 15 minutes. All the other speakers got 20, but that's probably...
I got 15 too.
Oh, you did? Okay. Bioinclusive dressings, managed comorbidities, wound surveillance, and post-operative antibiotics. Dave Provenzano, Tim Deere, and others did an international survey to see how well are we really doing with trying to minimize infectious and other complications of neuromodulation. And so the survey was conducted. 83% of the respondents were from the USA, 11% were from Europe. The majority were in private clinical practice. And again, the majority of individuals were able to perform an implant in under 90 minutes. That's the really important cutoff time. From the same data, antibiotic prophylaxis was only used in 90% of stimulator cases, meaning 3% of the respondents were not using any prophylactic antibiotics to do an invasive interventional procedure. I found it to be fascinating. Skin depilation, again, this is a CDC 1A recommendation, is to use skin clippers immediately prior to your procedure and not shave the night before or a week before the procedure. Again, this was only done in 74% of respondents. Cleaning the skin, even though it's a CDC 1B recommendation to use chlorhexidine and alcohol, only 28% of respondents were compliant with that recommendation. And how long to use antibiotics? Well, for the trial, again, 70% of respondents were using antibiotics for the trial, and about 50% of respondents were using antibiotics for greater than 4 days after a permanent implant. So that means that 50% of respondents are not using antibiotic prophylaxis going into the post-operative period. Interesting. So what do you do if you suspect an infection? Obviously, you make your clinical assessment, you draw your laboratories, you draw your erythrocyte sedimentation rate, your C-reactive protein, you assess the patient clinically. Do they have redness, warmth, swelling, pain, drainage? And gratefully, while infection is not a rare event, it's actually quite common. Death and paralysis are sentinel events. They're reportable events when they're associated with neuromodulation. They occur with great infrequency, gratefully. So in summary and conclusions, proper planning, of course, is the most important thing to try to avoid complications. Again, I do the complication talk at every lecture, so next time you want to see me at any meeting, you'll know I'm the complication guy. Determine if the patient actually needs a spinal cord stimulator. Try to avoid dural puncture because that's messy and that can lead to prolonged morbidity for your patient. Avoid deep sedation for your trials. Go slow, go easy, tread softly. And proper patient selection. Use your antibiotics on a weight-based basis. Use them into the post-operative period. Use your skin cleaning with chlorhexidine and alcohol. Use your clippers immediately prior to the surgical procedure. Brief operative times. If your operative times are exceeding 90 minutes, you're probably doing something wrong and may need some remediation. If you have a suspicion for an infection, get your laboratories, follow them serially, and manage your patients. Thank you very much for your time and attention.
Okay, before we bring up our headline.